Welcome back to The Explainer. Today, we're jumping straight into a massive medical mystery. We're looking at a category of diseases that is honestly just as complex as it is dangerous. It's this stealthy, invisible threat that slowly turns the soft, vital tissue of the lungs into stiffened scar tissue. For decades, this physiological puzzle has completely stumped doctors. But now, thanks to some pretty incredible diagnostic tools and recent genetic breakthroughs, the pieces are finally starting to come together.
All right, let's start with the number, 200. That is the staggering number of distinct individual lung conditions currently hiding under one single massive medical umbrella known as interstitial lung disease, or ILD. And because there are so many variations and because they carry such a high risk of mortality, making an accurate diagnosis isn't just important, it is absolutely crucial for patient survival. To solve these cases, doctors literally have to play the role of medical detectives, using a highly coordinated approach to piece together clinical, lab, radiologic, and histopathologic data.
So, to crack this case, here's our roadmap for today. We'll start by decoding interstitial lung disease, then walk through the diagnostic investigation, compare known versus unknown causes, line up the major ILD suspects, and finally, we'll explore the new genetic frontier.
Part 1. Decoding interstitial lung disease. First off, we really need to understand the exact nature of this threat to the lungs.
So what's actually happening here? The crucial point is that ILD primarily attacks the interstitial space, the delicate tissue right around the air sacs. But it definitely doesn't stop there. It aggressively involves the alveolar epithelium and endothelial cells too. The end result? Varying, very dangerous degrees of inflammation and fibrosis. Essentially, the lungs undergo this severe scarring and stiffening process, which acts like a wall, preventing oxygen from effectively transferring into the bloodstream.
Now, when doctors actually examine a patient, they're hunting for specific clues. People usually present with progressive exertional dyspnea. Basically, they get breathless just doing normal physical activity, along with a persistent dry cough and general fatigue. But the physical exam is where we find the real smoking gun. Doctors will often hear these end-inspiratory fine crackles, also called rales, right at the base of the lungs. They might also see digital clubbing, which is a swelling at the ends of the fingers. In late-stage disease, things get really severe, progressing to cyanosis, a bluish tint from lack of oxygen, and cor pulmonale, which is literally right-sided heart failure. And while most of these ILDs are a slow burn over months or years, the damage is totally relentless.
Moving on to Part 2. The diagnostic investigation. Because these symptoms overlap with so many other issues, how on earth do doctors isolate the real cause out of 200 possibilities?
Well, they use a standard three-step narrowing process. They start with non-invasive lung capacity tests, zoom in with highly detailed imaging, and if the suspect is still hiding, they go for the final, definitive move, a surgical lung biopsy to examine the tissue directly.
So in step 1, those pulmonary function tests usually flag what we call a restrictive ventilatory defect. Simply put, because the lungs are scarred and stiffened, they are physically restricted. They literally cannot fully expand, which leads to a reduced total lung capacity. But here's the catch. The airways themselves aren't actually obstructed, just restricted, so the ratio of air the patient can forcefully exhale remains normal or even elevated. Crucially, though, we see a reduced DLCO, meaning carbon monoxide diffusion drops. That scarred tissue acts as a barrier, ruining efficient gas exchange. Once they see this, doctors immediately move to step 2, the high-resolution CT scans, to see the extent of the damage.
Which brings us to Part 3, known causes versus unknown causes. Once an ILD is confirmed, doctors have to sort the suspects into two classic buckets.
Historically, the medical field has relied on a pretty strict dichotomy here. On one side, you have diseases sparked by known triggers. We're talking occupational hazards like asbestos or silica, specific medications like the drug amiodarone, or connective tissue diseases like scleroderma. But on the other side, the unknowns. This includes idiopathic interstitial pneumonias. And remember, idiopathic is just a medical way of saying we have no idea what caused this. It also includes granulomatous diseases like sarcoidosis and super rare disorders like LAM and PAP.
Let's dig deeper in Part 4, the major ILD suspects. Pinning down exactly who we're dealing with here is an absolute game changer for the treatment plan.
Look at the stark juxtapositions on this table. Idiopathic pulmonary fibrosis, or IPF, is the most common unknown cause. It primarily attacks older men over 60 with a history of smoking, and it shows this highly distinct honeycombing pattern of scarring on a scan. It requires targeted antifibrotic therapies. But contrast that with NSIP, totally different vibe. It typically strikes middle-aged, non-smoking females. On a scan, you see diffuse ground glass opacities, and honeycombing is actually super rare.
And the treatment? It relies on immunosuppressants, which are totally contraindicated for IPF. Then you've got COP, hitting patients in their 50s and 60s, showing a crazy reversed halo sign on scans and responding well to corticosteroids. Finally, there are smoking-related ILDs driven by pigmented macrophages accumulating in the lungs, where the obvious primary fix is simply to quit smoking.
Now, while most of those diseases take months or even years to develop, we have to talk about an incredibly dangerous outlier, acute interstitial pneumonia, or AIP. Also known as Hammond-Rich syndrome, this one is rare, terrifyingly fast, and often fatal. Patients suffer an acute onset of severe respiratory distress and plummeting oxygen levels in just a matter of weeks. When doctors look at the histopathology, it correlates with diffuse alveolar damage. It is quite literally the ultimate worst-case scenario in the ILD family.
And finally, Part 5, the new genetic frontier. For decades, cold cases like IPF were just dumped into that unknown bucket. But new DNA evidence is blowing that completely wide open.
Check this out. Geneticists recently discovered that a variant in the promoter region of the mucin 5B gene, MUC5B, is present in roughly 40% of all IPF patients. Let that sink in for a second. That one single genetic variant increases a person's risk for this devastating disease sixfold? This is a massive clue that challenges the whole known versus unknown paradigm. I mean, if almost half of these idiopathic cases actually share a genetic trigger, are they really idiopathic at all?
And it doesn't stop there. We're also uncovering that mutations in genes regulating telomere length, genes like TERT, TERS, RTL1, and PARN, are heavily implicated in lung scarring. You know, telomeres are what protect the ends of our chromosomes, so when they degrade prematurely, our cells age and malfunction. Finding these mutations in both familial and sporadic pulmonary fibrosis cases provides us with another massive genetic fingerprint right at the scene of the crime.
So this brings us to the ultimate question at the heart of today's explainer. As we rapidly uncover these genetic roots in our own DNA, like telomere degradation and that MUC5B variant, will we eventually dissolve the unknown category entirely? Imagine if we could reclassify these mysterious lung diseases from idiopathic to genetic. It completely opens the door for new targeted gene therapies that could one day stop this fatal scarring right in its tracks. It's a pretty profound thought to ponder as we look toward the future of respiratory medicine.